So, which drug do we want to use? Well, let's back up and remind ourselves that they all have short half-lives. The body is very careful about how long it lets the catecholamines sit around because they have such potent effects. So they all have extremely short half-lives. There's monoamine oxidase inhibition. We talked about this when we talked about behavior-modifying drugs. And they're everywhere. And then there's catecholamine O-methyltransferases, COMT. They're everywhere. They will degrade these compounds within milliseconds. All right, not within milliseconds, but within seconds. So the half-lives of these drugs are extremely short, on the order of 2 minutes. So these are not drugs that we bolus, unless we've got cardiac standstill. These are drugs, if we are using them for positive inotropic effects, we set up as a constant rate infusion. Epinephrine is the only one we're going to bolus, and in that we're going to use it for cardiac standstill. So, we can't give them orally for the same reason, because they're just too rapidly metabolized. So constant rate infusion. And the nice thing about this really short half-life is we can use the rate of administration as our response. The animal's heart rate is too slow, we up the dose a little bit by increasing the fluid rate. Heart rate's too rapid, we slow the fluid rate down, and within a couple of minutes we should see a response. Okay, so why dobutamine? Well, because it's the safest. This is dopamine. Dr. Judd talked to you about dopamine. He talked to you about its effects peripherally. What's one of the problems with high concentrations of dopamine? It causes norepinephrine release. And what's the problem with norepinephrine release? What is norepinephrine really, really good at? Good at vasoconstriction, alpha receptors, potent vasoconstriction, so much so that you can cause acute renal failure because of decreased renal blood flow. The other thing he talked to you about dopamine was increasing renal perfusion, but remember that was at lower doses. At higher doses, it causes norepinephrine release. So we don't want to use dopamine. So what we've done is we've just added a little group here and made it dobutamine. And when that happens, we've done two things. First of all, it doesn't release norepinephrine. Second of all, it's a better beta-adrenergic positive inotrope. So the nice thing about dobutamine is we have very little alpha-adrenergic effects, and it is better causing contractility and heart rate with less oxygen demand. So it's just a better drug compared to dopamine. Less tachycardia. We want to increase the heart rate, but we don't want to increase it so badly that we get the animal in trouble. So it is the preferred drug for short-term management, short-term positive inotropic effects, maybe even increasing heart rate in a patient that is having trouble in congestive heart failure. So it is the preferred drug. Let me tell you what drug is not to be used, and that is epinephrine. I ask this question every year. I tell the students every year, if I ask you a question, what is the drug to use for emergency management of a patient on the surgery table? What beta-adrenergic drug would we use to support the patient? I do not want to see epinephrine as your answer. You will kill your patient. We use epinephrine for cardiac standstill. Imminent cardiac standstill. Maybe it's ventricular fibrillation, maybe it's ventricular standstill, but epinephrine is the best drug for getting things back on track. It is the best drug to get the heart going again. But it's also the best drug for killing your patient if you're not careful, okay? So, it is a great positive inotrope, it is a great positive chronotrope, it is a great vasoconstrictor. It does have alpha effects. I understand they're not as much as norepinephrine, but it still has alpha effects. It is extremely arrhythmogenic. It is extremely myocardial oxygen demand increasing. So, cardiac standstill. Now, it's nice things about it. So, those of you that have allergies, the EpiPen, why do we use it in allergies? What does it do so well? Bronchodilates. You're about to die from histamine-induced bronchoconstriction. You use an EpiPen, and that will cause you the bronchodilation. What else is going to happen? What's your heart going to do? as if it's not beating fast enough. It's going to beat more rapidly, that's right, and your blood pressure is going to go up, okay? But all these things actually are probably good because of that histamine release. You've actually decreased your blood pressure anyway. So there are alternative routes of administration, sub-Q, actually inhalation, IM. Ideally, though, that we're going to give it either IV rapidly or some route of administration for the cardiac standstill patient. So indications, imminent cardiac standstill, and then non-cardiac indications for bronchodilation, and then, as we said earlier, local vasoconstriction if we are trying to use this drug, if we're trying to use lidocaine for pain management, local anesthetic. Now let me say one more thing. I don't have a slide for it, but if all you want is to increase blood vessel vasoconstriction, you're not interested in increasing heart contractility, then you can see norepinephrine used in a patient that is hypotensive on the surgery table. I still think you're probably going to see dobutamine used more. But some clinicians, and in human medicine, they will use norepinephrine for vasoconstriction. Is that making sense? They're not using it for cardiac standstill. All right, so the last slide is just to remind you, sometimes we're trying to decrease contractility, and that's going to be the cat with hypertrophic cardiomyopathy. We can't really decrease contractility. Well, I guess we do, but that's really not what we need. What we really need is to relax that heart. And negative inotropes are not necessarily going to do that. But nicely, most of the negative inotropes that we use actually slow the heart rate down as well. And so that's really what the M is benefiting from. So what we need to keep our eyes out for is a drug that relaxes the heart. Probably diltiazem does that better than beta blockers, but I don't know that for a fact. And that's it. Yeah. So a couple of housekeeping rules. Or housekeeping issues. Health session Thursday, right? How'd that parasitic exam go? I had 4 people at the health session, and they are so much smarter now, right? They learned a lot about cardiac drugs, and they were good questions. I think it was 4 people, maybe 6. Good questions. So I'm thinking we probably need to have a pretty good health session this Thursday. What do you think? Yes. All right, so let's make sure that gets done. Now, just to let you know, I'm leaving Friday, so I'm going to be pretty anxious about getting out of there and packing up Thursday. So be there on time. I will be willing to go past 5 if we need to. But please come with your questions, okay, so that we can make it an efficient experience. And